Hi, and welcome back. We are at Sorbonne University, Paris, North Bobigny. And now it's our French roundtable. How to use HoloLens in all surgical specialties. Let me the pleasure to introduce you, our guest, Professor Emmanuel Martineau. Thank you to be here. You organized that roundtable. You are a thoracic and vascular surgeon at Hôpital Avicenne. It's really across the street. Professor Audrey Gioconti, you are ophthalmologist at Avicenne Teaching Hospital too. And professor also here at Université Sorbonne Paris Nord. Thank you to be with us. And we have Professor Marc Pocard. It's surgery, digestive surgery at La Pitié-Salpêtrière. It's in Paris. And Professor Christian Debris, otolaryngologist at Teaching Hospital in Strasbourg. Bienvenue, welcome to you all. Professor Martineau, I'll let you introduce that roundtable.
Thank you very much, Emmanuel. Thank you, Audrey. Thank you, Christian and Marc, for being here today. I think that the intraoperative application of such emerging technologies can offer today new possibilities. This includes a better performance during the procedures, preoperative planning, surgical simulation, and training. In thoracic surgery, a potential application of real-time augmentation of the surgical field will be intraoperative guidance for small pulmonary nodule localization.
Yeah.
And this requires a cone beam CT scan in order to perform direct lung resection during, for example, VATS surgery. And the goal of this procedure is to look at the nodule through the lung, and it's very exciting for a thoracic surgeon. Another application would be the guidance of lymph nodes detection using indocyanine green fluorescence in the field of lung cancer surgery. And I think that it could be very interesting for the future. I don't know if it's for 2050, but maybe earlier than that. But maybe it could be very interesting for future development. Audrey, what do you think in your specialty of ophthalmology?
Thank you, Emmanuel. In ophthalmology, currently we have two kinds of devices in the operating room. There are numerical interfaces between the patient and the surgeon. And this allows us to be not just behind the microscope as usual, but there are two systems. One is heads-up surgery. So we are in front of a screen, seeing the inside part of the eye in 3 dimensions. This system is already commercialized. And the other one is vision goggles, connected also with the microscope. But in this case, the surgeon is more isolated from the rest of the environment of the operating room. So two systems, and we can combine the previous surgery imaging to the real image in 3D.
Okay, let's see at digestive surgery with Professor Marc Pocard, La Pitié-Salpêtrière. In your specialty, Marc Pocard. Marc Pocard, on vous entend pas du tout. We cannot hear him. So, waiting for Marc Pocard, we're going to ask. It's okay?
Yes, it's okay.
Marc, okay, Marc, welcome. Yeah, so in your specialty, tell us.
My specialty is cancer surgery, and I perform surgery. Majority of my surgery is for peritoneal disease, which is small implant of tumor inside the peritoneum. So to my point of view, the future will be the association of EA computers and biology. What I'm waiting for is to be able to have something for each tumors, specific for each tumors, that we can detect during the procedures. A sort of light, specific light put on somewhere, or a noise, or a way to say to the surgeons that part of the body is affected by the disease and that part not. To try to select the patient and to select during the procedures what is important to resect the disease and what is not important to be resected, and put that away to have more security and more good results.
Yeah. Okay, we get that. And Professor Christian Debris, you are otolaryngologist at Teaching Hospital in Strasbourg. What about those new technology in your specialty?
In our specialties, for me, I am working in school-based surgery. There is very little place inside, and we use for many years the system device which permits to locate the top of the forceps during the operating. It's very classical. We have some idea for many years about virtual surgery. We worked and for many years on this subject, but it's not used. It's not. Yes, we have not the possibility to work actually with complete virtual surgery. But so we just use system device which locates the top of the forceps inside. It works very nice, but it's only a few moments during surgery in our practice, but it's used essentially for school-based surgery.
Okay. And Emmanuel Martineau, what are the other areas that will revolutionize surgery in the future? What would you say?
Yes, most probably the future of surgery will indeed be based on the technological developments such as mixed reality, artificial intelligence and robotics, but also on the use of artificial organs to repair damaged tissues. Mm-hmm. And for example, every year in the US alone, 1 million people die from heart, lung, kidney, and liver failure. 1 million. And many patients on transplantation waiting lists will die before a donor organ becomes available. And recent advances in regenerative medicines have allowed to consider the possibility of creating organs and tissues using ex vivo or in vivo techniques. And to create artificial organs, we need matrices, most often decellularized or cryopreserved matrices. We need cells that can repopulate the matrices, and in vivo or using the natural bioreactor, the human body, or in ex vivo bioreactors. And we are working for a long time on at our center on in vivo airway bioengineering using stented aortic matrices. And it's very fascinating because we have today clinical series including 30 patients. And the results are very encouraging because the majority of patients showed after implantation of this type of matrices, de novo generation of cartilage within the matrices. And we have now a lot of projects. The name is Saturn Project, with a lot of collaboration. For example, with Christian in Strasbourg, for developing laryngeal transplantation. Christian?
Yes, it's true. I agree with you, Emmanuel.
D'accord. Très bien. Merci.
And So, sorry, Emmanuel, could you repeat your question for me?
No, I've just summarized our collaboration.
Yes.
And
I agree with you. Marvelous collaboration.
Yes, on laryngeal transplantation.
And laryngeal, we are waiting for the first laryngeal transplantation. The first one in 2012, but it was only with biomaterials, but thanks to Emmanuel and development of allograft, we have the authorization now for 4 patients to implant 4 patients now in next month, not now, some weeks for this year, for new patients for after total laryngectomy to replace the organ by an allograft, thanks to the works before made by Professor Martino. So we hope we have a lot of. We hope it will. It will be safe for our patients because there is many total laryngectomy in the world every year, and all of these patients have a definitive tracheostomy. It's very difficult for them for the rest of their life. So we are dreaming of doing to replace this organ with these new techniques and allograft.
Professor Marc Pocard and Professor Audrey Giocanti, this need of artificial organs, artificial tissues, it's a tool for all of you on today.
Exactly. In ophthalmology, for example, we have a prosthesis of the retina. They are still in development. Some of them were implanted even in France a few years back, and we have good results because they were implanted in blind people, and they restored a little bit of vision, the possibility to walk for patients and to see big letters. And these need to have a healthy optic nerve, but we can replace retina. So these need to be still improved, but we are developing it.
Marc Pocard, all those new technology should help to progress in this subject.
I think that security is important in the operative room. Yeah. And we can imagine that actually in all the different places we use checklists and to try to be sure that this is a good patient, that the process is correct, and all that things. And I think that part of that could be more developed in the future, the security. By example, you know that tomorrow we will use a car that drives alone, and today you can use a car, and if you are not in the good direction, the car says to you, you're not at the good place. So I know that a lot of colleagues waiting to have a sort of process insurance during surgery. And that could be interesting too, and probably for all the different type of surgery.
Yeah. Another topic is training, learning, intelligence, mixed reality, artificial intelligence can help, really. We've seen that with HoloLens 2 today. With HoloLens in orthopedic surgery, we are in the eye of the surgeon. It's just incredible to learn, to see.
Yes, it's true. I think that to have surgical innovation, we need surgeons first. And first of all, it's a very big issue in all countries to have performed new generation of surgeons. And I think this kind of technologies could help for training of young surgeons. Yes, it's true.
Yes, in ophthalmology too, because when you are in the operating room, usually you are behind the microscope with your help, and you're just two of you to be able to see what you are doing. Here, with the heads-up systems, you have a screen, and everybody can see and learn the surgery. So it's a good thing, I think, to develop it.
Pascal de Wild, vous venez de nous rejoindre. Merci d'être avec nous. Vous êtes directeur du groupe hospitalier à PHP Hôpitaux Universitaires de Paris Seine-Saint-Denis. Vous avez entendu des chirurgiens s'exprimer sur le plateau. On parle de réalité mixte, on parle d'intelligence artificielle. Vous devez être fier d'avoir tous ces chirurgiens aussi impliqués. Je pense évidemment aussi au professeur Thomas Grégory qui a largement pris part à la naissance de ce projet qui a mis en scène des chirurgiens dans le monde entier avec ces nouvelles technologies.
Merci. Bonjour. Bonjour à toutes et à tous. Effectivement, je suis très fier. Je suis venu en quelque sorte dire ma fierté pour cette manifestation qui fait suite à la première mondiale de 2017 avec les équipes de Thomas Grégory. Et comme vous l'avez souligné, je suis entouré de chirurgiens universitaires de notre groupe hospitalier qui consacrent beaucoup de temps précisément à l'innovation. Nous sommes le CHU de ce territoire. Vous le savez, nous sommes l'un des 6 groupes de la PHP, qui est le CHU Île-de-France. Et dans le territoire de la Seine-Saint-Denis, c'est nous qui avons cette tâche de remplir toutes ces missions d'enseignement, de soins et de recherche. Et au moment où, avec le professeur Martineau, qui est le président de la communauté médicale, on écrit le projet d'établissement des années à venir, eh bien, la première partie du document qui commence à s'incrémenter, c'est l'innovation. L'innovation dans toutes ses formes, et puisqu'on parle de chirurgie, l'innovation en orthopédie, une fois de plus, je salue la qualité de ce qui a été fait, mais l'innovation aussi, le professeur Martineau parlait de sa collaboration avec son collègue de Strasbourg, c'est l'innovation aussi, par exemple, en matière de greffe de trachée, pour lequel, grâce à l'équipe de M. Martineau, il y a eu aussi une première mondiale ici à Avicenne. Et effectivement, c'est un sujet de fierté. Et pour l'avenir, puisque je parlais de territoire, notre rôle, nous sommes dans les locaux de la faculté de médecine de Sorbonne Paris-Nord. C'est évidemment, le rôle de la faculté, c'est de former des médecins. Et pour nous, le CHU, c'est de contribuer à la formation des médecins. Et par rapport à tout l'environnement de santé, c'est d'être véritablement le leader universitaire d'enseignement, de recherche, d'innovation. De recherche, nous avons plusieurs unités de recherche fondamentale dans notre groupe hospitalier. Il y a beaucoup de recherche clinique. Et puis l'innovation technologique, eh bien évidemment, c'est un pan important qu'on va essayer de faire fructifier dans les années à venir au travers de ce projet d'établissement, et je l'espère avec des financements qu'on réussira à trouver.
Eh oui, c'est un peu le nerf de la guerre. Merci infiniment à tous d'avoir participé à cette table ronde.